Hi. Okay. I apologize if there was any confusion today on the group me. I do not have Zoom sessions on Tuesdays. If I ever make that mistake, just let me know. Sometimes when I make an announcement or a calendar event, sometimes it puts today instead of the day that I want. But without further ado, if you have any questions, you can email me or text me on group me, and I'm going to respond as soon as I can. So I want to talk about some things with fluid and electrolytes because I know it can be very confusing, and I want to make this really, really easy for you so you can study less and understand more. So we have crystalloids, which are different types of fluid. Now we have isotonic, hypotonic, and hypertonic. Now, all of these fluids are used to either create a shift from fluid moving from the cells to the body or vice versa, or we don't want to make any shift and we want to just keep things the same. Isotonic means that we're not going to have any shift in volume. So fluid's not going to go from the cells back to the body or vice versa. So isotonic solutions are things, like I said, do not cause any fluid balance changes. So that includes our 0.9% normal saline, our lactated ringers, and 5% dextrose in water. Then we have hypotonic solutions. Now, hypo means that the cells are really fat, okay? They're not like that normal cell shape. They're like really big. So in that, a hypotonic cell is swollen. Just think about that for now. But hypo usually means low. So this is lower than the isotonic fluid. So it's going to be 0.45% normal saline compared to 0.9% normal saline as we saw in isotonic. And it will be 2.5% dextrose instead of 5%. So it's a smaller amount than isotonic. Hypertonic is when the cell is like really shrunken and shriveled, okay? Like think about like a tomato and think about it when it's like really dried, right? And crushed. That's kind of what a hypertonic cell would look like. And hyper means high. So that's going to be higher than our isotonic values. So 3% normal saline, dextrose 5% water in normal saline, and 5% normal normal saline or NaCl. Okay, so you could usually think about these solutions as looking at them from the isotonic solutions. So hypo is going to be lower than those values, and hyper is going to be higher. And a rule of thumb that actually Professor Remy taught me was that when I had her for lab is that anything that has two fluids, so like dextrose 5% in water and normal saline, anything that has two fluids would be a hypertonic solution. Now, your question is, why might I use these solutions? Like, what are they for? Well, an isotonic solution, as I said, we might not want any sort of fluid shift. So we might give this to someone who's dehydrated just to get some fluids and electrolytes because normal saline has things like sodium and chloride in it. That's why we might also refer to it as NaCl, but on your exams, it'll be normal saline or NS. Hypotonic is given in a situation when someone has hypernatremia, meaning a high sodium level, so greater than 145. That is because if you have hypernatremia, right, you have too much salt, right? So imagine a cell and all that salt on it. It's making it shrunken and shriveled, all that salt. But a hypotonic solution makes a cell get bigger. It puffs it up. So when we give a hypotonic solution, what we're doing is actually correcting that electrolyte imbalance by getting that fluid into the cell, which is diluting that salt level and reducing the salt. So in a hypernatremic patient, we give a hypotonic solution like 0.45 normal saline or 2.5% dextrose in water. Hypertonic means, like I said, the cell is really shrunken and shriveled. We give this type of solution to a patient who has hyponatremia. Why? Because in hypo or low sodium levels, less than 135, that cell is really fat and puffy, right? All that salt and stuff, there's not that much salt in there. So because of that lack of salt, there's going to be a big fat cell, okay? And that hypertonic solution, because it makes things shrink, it's going to shrink that cell by aiding and giving more salt to make the cell go back to its normal shape. So there's like a balance, right? If something's high, I give it something lower. So hypernatremia, I give a hypotonic solution. If they have hyponatremia, I'm going to give a hypertonic solution. Okay, so things that I want to go into is things that you're definitely most likely going to be tested on. So this includes things like fluid volume deficit and fluid volume excess, either called hypovolemia or hypervolemia. So something that I want to point out with these is that I feel like when you know one, you know the other. So if you can memorize or understand one of them, you know the other. So some really key takeaways, right, is if you have fluid volume deficit, you're typically going to see someone having hypernatremia or hyperkalemia. This is because they're losing volume from the body. And as a result, the body's going to increase those electrolytes to try to make some sort of balance. So we might have hypernatremia and hyperkalemia. But regardless of that, they're not going to as much ask you about if fluid volume excess or fluid volume deficit will cause hypernatremia or this and that, but it might be just good to look at it and understand it for yourself. The major key points is what comes next. So tachypnea and a rapid thready pulse, okay? So they're going to have an increased respiratory rate of greater than 20. They're going to have tachycardia or a heart rate greater than 100, but it's going to be rapid and thready, okay? That is something that you want to know for fluid volume deficit, right? Because imagine if you don't have enough volume in your body, right? It's going to be a slightly weak pulse, but it's going to feel very rapid because the body's trying to compensate for that loss of fluid and trying to get something out there. So it's going to be rapid but thready, okay? That's a really important point. If you're losing fluid, you're going to have weight loss because you're losing that fluid, which means you're losing volume from your cells, from your blood. You're going to have weight loss. Orthostatic hypotension, you are losing fluid, which means your blood pressure is going to drop. That's the same sort of mechanism that those diuretics that we spoke about in my cardiac lecture relate to, right? In diuretics, they remove fluid from the body and it causes a decrease in blood pressure. So if you have fluid volume deficit, there's some reason why you're losing fluid. Like let's just say this person is having like a GI bug, like a little stomach virus. They might have orthostatic hypotension. They might have a low blood pressure. Okay, so increased heart rate and low blood pressure. Also, something to point out is that the low blood pressure, when somebody has fluid volume deficit, they're going to have a lower blood pressure. But your body tries to compensate. Goes with any mechanism. When your body lowers the blood pressure or anything lowers your body's blood pressure, your body responds by increasing the heart rate. So that is why we have a decreased blood pressure, but an increased heart rate, okay? Fluid volume deficit, we're also going to have oliguria, which means a urine output less than 30 ml per hour. That is because they don't have enough volume to pee out. Lab values. This becomes very important because when you're looking at your labs for someone who's dehydrated, you expect all of them to increase, okay? You expect your creatinine to increase, your BUN to increase, your hematocrit, and your hemoglobin. And this is because I think of the fact that you're losing that volume and you're losing that fluid, which is going to, as a result, make everything increase as a compensatory mechanism. The urine-specific gravity, which I think is the most important one out of all of them, is because the urine-specific gravity, which is typically 1.05 to 1.030, is going to increase because if you're not peeing enough, if we're having oliguria, we're going to have an increase in that concentration of urine because whatever's going to come out is going to be highly concentrated. And urine-specific gravity deals with the concentration of urine, so it's going to increase or be greater than 1.030, which means they're going to have concentrated urine, okay? And they're also going to have confusion, cool skin, and a capillary refill greater than 3 seconds. Normal capillary refill is less than 3 seconds. Capillary refill is when you take one of your fingers, you press down on it for a couple seconds, and you let it go. You'll see the bed of your nail turn white and it'll go right back to pink. It should do that in less than 3 seconds. That means we have good perfusion. But in someone who's dehydrated, we don't have good perfusion, right? We have a low blood pressure, which means our body's not getting as much fluid as we need as a compensatory mechanism. We have an increased heart rate, which means they're not really getting good perfusion, or else we wouldn't have these compensatory mechanisms in play. The confusion is also in part of due to that low perfusion, and the cool skin is the same reason, right? That lack of perfusion. Fluid volume excess or hypervolemia is the opposite. So instead of tachypnea, they have bradypnea. Okay, and they have crackles and a cough, right? Because if they have fluid buildup, that fluid buildup might go in their extremities, but it also may go in their lungs. So we expect to have crackles, and a lung assessment, especially for these patients, keep that in mind, is very, very important. They will have weight gain. They may have tachycardia, but they're going to have a bounding pulse because of all that pressure. It's going to make it bounding, whereas the pulse and fluid volume deficit was rapid and thready, okay? Edema, once again, fluid buildup means they have weight gain because of the edema or the fluid staying in their tissues. Now, the opposite, fluid volume deficit cause those lab values to increase. These are going to decrease because of that increase in fluid diluting everything, okay? Also, when you have fluid volume excess, you're peeing a lot. There's no issue about having oliguria or a urine output less than 30 ml per hour. So the urine-specific gravity is going to decrease because the urine is more diluted. Okay, other things that happen is that we have a high blood pressure. Why? Because of all that fluid buildup, right? So all that fluid is putting pressure on those vessels, which is increasing our blood pressure. And we'll also have a distended jugular vein, which is a vein that runs in your neck. It's going to like pulsate and come out, okay? Because of all that fluid excess, which is really, really not a good sign, okay? So that's the major differences between these two, okay? This is more about it, but regardless of either, think about it. All of these fluid volume deficit, fluid volume excess cause blood pressure changes. So what do I want to watch out for both of them? Blood pressure changes, okay? What else do I want to do? One causes weight loss, one causes weight gain. I have to do daily weights, okay? What else? Heart rate changes. I need to look at the heart rate. What else? For my fluid volume excess patients and my fluid volume deficit, I need to watch their I&Os. I need to watch what's coming in and coming out, right? Because for those fluid volume deficit patients, I want to give them fluid because they don't have enough fluid. That's what's causing this problem. In fluid volume excess, they have too much fluid. They have too much. So we want to reduce that. So we really want to watch the I&Os for both of them, right? Another thing, especially for that fluid volume deficit, is I want to watch out for mental status, right? Because I said that can cause confusion. Other things is the skin. The skin assessment is important for both of them. Why? Because one causes edema, right? And the other can cause potentially dehydration. That fluid volume deficit can cause dehydration where the skin turgor is poor, which means that when you pull your skin underneath your clavicle, it should normally go right back down. But it doesn't because these patients are dehydrated because they don't have enough fluid. Whereas in fluid volume excess, you probably have a hard time pulling their skin because it's just so swollen. So skin assessments are very important. Now, certain things that might differ is that with that fluid volume excess, we really got to watch the lung assessment to make sure they're not having any sort of fluid buildup in their lungs, okay? So, like I said, most of those nursing management considerations have to do with those symptoms that we already talked about. The major differences come in is, should I give fluid to this patient or do I not give fluid to this patient? What lab values do I expect to see? What symptoms? Yes, those differ slightly, but those nursing management, the I&Os, the daily weight, oh my, that's going to be super, super, super important. So you must know that, okay? And as I mentioned, diuretics can be used to treat fluid volume excess. Why? Because they pull fluid from the body. So if it's going to pull that fluid from the body, this can be really good for them taking a diuretic. But as we mentioned, and I mentioned before, diuretics cause electrolyte imbalances. So we got to watch out for that too. But the overall takeaway is that for each of them, you're looking at INOs, you're looking at daily weights, you're looking at skin assessments, okay? Daily weights, same time, every single day, same clothing, same scale. That is definitely going to be on your test. Looking at INOs, yes, okay? Skin assessments, yes. Lab values, yes. Monitoring vitals, monitoring blood pressure, all of that is going to be interventions for both. There's just certain ones that differ, such as the crackles that we might see in fluid volume excess. And as I said, the mental status changes that you might see in fluid volume deficit. Otherwise, all of these interventions start to be the same, okay? And as I said, fluid volume deficit, we want to give them fluid. Fluid volume excess, we don't want to give them fluid, okay? Or not as much. Now we're going to talk about electrolyte imbalances, right? Some of these can be caused by one of the drugs that we know, like diuretics. They cause pretty much low of everything. But I want to make these electrolytes very clear-cut and very simple to understand, okay? So you might want to use the mnemonic SALT laws for a hyponatremia. And as I said before, if you have hyponatremia, we're going to want to give them a hypertonic solution like, I don't know, 3% normal saline, okay? And that means hyponatremia means a sodium level less than 135, okay? So I would know the mnemonic SALT loss, which means stupor, anorexia, lethargy, tachycardia, limp muscles, orthostatic hypotension, seizures, and stomach cramping. However, the most important ones is seizure, stomach cramping, and lethargic, the confusion, okay? Those are the three most important ones. Why do I say that? Because the sodium levels, whether hyponatremia or hypernatremia, which means low sodium, high sodium, they both can cause seizures. So our priority for someone who has a salt imbalance is seizure precautions, okay? But other things include stomach cramping, which is something I've seen on my own exams, and lethargy, right? This confusion, which can lead into the seizures. So we really want to watch out for that, okay? Now, hyponatremia can be caused by, let's just say, vomiting or diarrhea, right? If, like I said, if you have a GI bug, you vomit, diarrhea, you're removing electrolytes from your body, okay? And other things like medications, like diuretics, can also be the culprit. That's where that pathophysiology comes in. Nursing management of hyponatremia, very, very important, okay? Seizure precautions, that is your first. That is your first choice. Then you're looking at assessments of the INOs, the weight, the lab values, okay? And any mental status changes, because as I said, they can become lethargic, which means confused. So we want to look at those things. We want to restrict tap water because if I'm understanding it correctly, I remember when I learned it, they said there's something in tap water that's going to further hurt the low salt levels. So we do not want to give them tap water. Okay. So keep a note of that. No tap water. But think about it also, right? These patients have low sodium levels. So what would I want to give them, right? I said about seizures. I want to watch mental status changes. I definitely want to watch what they're intaking and outputting, right? Especially we want to avoid that tap water, but we'd also want to increase their dietary sodium because their sodium levels are low. So we want to encourage them to take sodium supplements or just include more sodium in their diet. And as I said, for these type of patients, we want to give them a hypertonic solution. Then we have hypernatremia. Okay, so hypernatremia means salt greater than 145. So a mnemonic is fried salts, flushed skin, restlessness, increased blood pressure and fluid retention, edema, decreased urine output, skin dry, mucous membrane dry, swollen, sticky tongue, agitation, low-grade fever, thirst, seizures. You just heard me say a lot of that stuff. How am I going to memorize that? Well, you have a mnemonic, fried salts for hypernatremia, but the most important ones I would say is the flushed, the restlessness, okay, the seizures, the increased thirst, and those dry, sticky membranes, okay? Here's the thing. They have salt, really high salt levels. Now, imagine when you eat like chips and you keep eating them and you're not drinking. Your mouth gets really dry and you get really thirsty because you need something to dilute that salt. That is why they're going to have a dry, sticky membrane, okay? Because all that salt, it's nasty, okay? So all that salt is making it all dry. Seizures, as I said, seizure precautions is your priority for both of them. But hypernatremia causes things like a flushed skin and also causes mental status changes. So we want to watch out. And that's in part because of the potential of a seizure, okay? So we've got to watch for a mental status change. And they're going to have thirst because of the that dry stickiness that they're feeling, right? Like I said, the example with taking in too much salty things. Another thing is increased blood pressure. Why would hypernatremia cause increased blood pressure? Well, anywhere salt goes, water goes. So if there's an increase in salt, there's an increase in water, and volume can be a reason why your blood pressure goes up. So the volume would increase as a result of the sodium levels increase, which is causing an increase in blood pressure, okay? So some causes I mentioned before, fluid volume deprivation can potentially cause hypernatremia, too much salt intake, and hypertonic solutions can cause hypernatremia because they have more salt. That's exactly why we wouldn't give a hypertonic solution to someone who has hypernatremia. We give a hypotonic solution. Like I said, nursing management, seizures priority. We want to reduce salt intake, right? Because they already have too much. We want to watch for mental status changes, okay? So it's seizures is your priority, mental status changes, watch the blood pressure, okay? And teaching point, we want them to increase their sodium intake. Hypokalemia. Now, hypokalemia is really, really important. It's one of those important lab values because as you're going to learn with your antiarrhythmics that I'm going to be talking about on Thursday, is that potassium actually plays in that SA node, the electrical conduction system in your heart. It plays a role in that, which means it can affect your heart in simple terms. Hypokalemia means a low potassium level, less than 3.5. The most important thing is EKG changes and muscle weakness, okay? So just to give you a visual, I want to share a new screen. Hopefully you all are all seeing this, but I'm going to change the color. So the red one is an example of a regular EKG. So a regular EKG is you have your normal PQRS. So I'm terrible at drawing this, but this is a P, this is an R, this is a Q, this is an S, and this is a T, okay? Sorry, it's not the most appropriate, but that's a normal EKG. In hypokalemia, what happens is that T wave in low potassium levels makes an inverted U wave, which is also known as a depressed T wave or an inverted T wave, okay? So it changes this T wave. So this T wave that in a normal EKG right here, it changes and now looks like this when the potassium level is less than 3.5, okay? Please don't mind my terrible handwriting, okay? So that's the EKG changes. That is why with potassium levels, the most important thing is to monitor the EKG, okay? So going back to my notes, we really want to watch out for this inverted U wave or what we call a depressed T wave, okay? So causes of it can be medications like diuretics. They always cause lower electrolyte levels, vomiting, throwing up, NG tube suctioning or something like that. But especially if this is a med-surg focus exam, we're going to look more at the interventions. And if this is a patho focus exam, you want to know the types of things that might cause a problem with hypokalemia. And as always, anytime it's low, there's always the potential of a dietary issue, right? Low sodium, low potassium are results of potentially not intaking enough in their diet. So education is going to be, hey, take more salt or take more potassium when their levels are low. Example, bananas, the most common example of potassium. So when they have hypokalemia, tell them, increase your banana intake, right? Take in your whole grains, your milk, lean meats, and your fresh frozen vegetables, never canned vegetables because they're really high in salt, okay? EKGs, that is your most important thing, those EKGs, okay? Also, you don't want to give potassium until after urine output is established because potassium leaves in the urine. So if for some reason we're giving them potassium and then their levels get too high and they can't really pee, then that's going to be a problem. Okay. Now, something else that they might get is we want to monitor those ABGs to cause something. It can cause something from, hypokalemia can be as a result of metabolic alkalosis, which is another way of saying NG tube suctioning, throwing up, nausea, and vomiting. Okay. So we want to really, really want to watch out for that. So another thing that I want to just emphasize is the two major points, if you can't remember anything with hypokalemia, is the EKG changes and muscle weakness for symptoms. Okay. It can be caused by something vomiting or GI disturbances like throwing up, things like that. And we want to monitor those EKGs, okay? We really, 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 that's the priority here. Another thing, going back to my whiteboard, is if hypokalemia does something to the EKGs, so does hyperkalemia, okay? So hyperkalemia causes that T wave to get really big. So the T wave is now going to look like this, okay? It's going to be abnormally big. So this is not good, okay? So this shows that there's something going wrong with our cardiac system. So when potassium is greater than 5, okay, it looks like this tall peaked wave. But when it's less than 3.5, it looks like a U wave, okay? So now that we've established that, some important mnemonic that you can learn for hyperkalemia or a potassium level greater than 5 is the mnemonic called MURDER: muscle weakness, urine abnormalities, respiratory distress, decreased cardiac contractility, EKGs, reflex increases. I would remember for hyperkalemia, the reflexes increase. I remember EKG changes and muscle weakness, okay? But the priority is the EKG changes, and I would really remember the reflexes increase as well, okay? Now, hyperkalemia is really caused by either too much potassium or renal failure. And renal failure is because if the kidneys fail, the kidneys are in control of our electrolytes. So if the kidneys fail, we can't keep those electrolytes in check and they're going to raise. That's also why renal failure can also be a cause of hyponatremia for the same reason. Medications. These medications that I'm going to tell you right now are going to be on your med-surg exam. I know they're on mine, which means they're going to be on yours, okay? So things that we want to watch out for is we want to watch out for these medications because these medications are going to be used to treat hyperkalemia. So these medications include 50% dextrose IV push, 10 units of regular insulin, 1 gram of calcium gluconate, Kexalate, and 1 unit of albuterol. All of these push the potassium back into the cell. But Kexalate, the thing that Kexalate does is it actually allows you to poop out the potassium. So we have to really monitor the bowel movements because we want that potassium to leave. So they should poop after we give them Kexalate. I would know Kexalate and I would know all of these medications that I told you right now. Okay. Management includes watching that EKG and looking at those vital signs, especially because if their heart rate is increased or something's wrong with the heart rate, right? That could also be indicating that there's an EKG problem. But the priority, if there was a question and they were saying, what should I do as a nurse who, knowing that this person has hyperkalemia, I'd want to look at those EKGs. I want to make sure that they're not having, any of those changes that we talked about before, okay? Now, the next part is going to be very simple. If I have to sum up everything that we did before, sodium levels, priority seizures, potassium levels, priority EKGs, okay? Next thing is calcium levels. Now, I'm going to make this real quick. I'm not going to spend any more time than I need to because I know you all have studying and I have things to do too. But this helped me. So there is a relationship between calcium, magnesium, and phosphorus, okay? There's also a relationship between sodium and chloride. So just to bring back those sodium, anytime sodium decreases, chloride will also decrease. Interestingly enough, when sodium decreases and we get those, symptoms of like the stomach cramps, the seizures, the things that we were talking about before, mental status changes. It's the same thing for hypochloremia, okay? So the symptoms in hyponatremia or low sodium levels are the exact same as low chloride levels because sodium and chloride go together. Same thing for hypernatremia. The symptoms of hypernatremia are the exact same symptoms as hyperchloremia because they go together. They are interchangeable. Wherever sodium goes, chloride also goes. Hypocalcemia has or calcium levels in general has a very similar thing. The manifestations of low calcium are going to be the same manifestations of low magnesium levels. Just keep that in mind, okay? High calcium levels are going to be the exact same symptoms, or the presenting symptoms are going to be the exact same in hypermagnesia, okay? So keep that in mind. Hypocalcemia means a calcium level less than 8.5, okay? Now, calcium is controlled by the parathyroid hormone. And a mnemonic that helps me is cats go numb. So we have convulsions, arrhythmias, tetany, spasms, or seizures, and numbness. So I would know this mnemonic heavily. I would know all of them, okay? Seizures is something that we see in calcium, especially low calcium. So these patients are also going to be on seizure precautions, okay? But really importantly, this is a giveaway. You will definitely get a question that says a patient has Chesevic sign or Trosevic sign, and they're positive for that. Positive for that sign means that they're exhibiting that sign. What electrolyte imbalance do they have? It's going to be hypocalcemia. So Chesevic sign is when you tap the cheek and their cheek spasms. Normally, if you tap your own cheek, it's not going to do anything. But someone who has low calcium levels, they're going to have like a little muscle twitch, okay? And that's because in hypocalcemia, think of it this way. It's like when the calcium levels are low, it actually causes a stimulatory effect. So it's like when you press that cheek, it kind of causes your muscles to twitch out. That's what the tetany is, or spasms, okay? Trusor is the same thing. Trusor is when you put the blood pressure cuff on your arm and you press it and make it really, really high, and their hand like twitches, okay? So if you see a positive Chesevic sign in Trusor's time, I already know that means it's hypocalcemia or low calcium levels, okay? Now, I said that calcium is controlled by that parathyroid hormone, okay? So parathyroid hormone controls calcium. So when you have hypocalcemia, you have hypoparathyroidism. Know that. It's going to be very important, okay? So management of hypocalcemia means we're going to restore calcium levels. So we want to give them calcium gluconate, seizure precautions, because they can have seizures, and replace those calcium levels. Okay, that's our priority, to replenish those calcium values, okay, and get it back up to normal. Now, I just want to go back to this idea with the parathyroid hormone, okay? Because like I said, it goes back with calcium. So remember, when calcium's low, the parathyroid hormone is low. And please remember, cats go numb for the symptoms. Hypercalcemia means a calcium level greater than 10.2, okay? Now we have the mnemonic back me: bone pain, arrhythmias, cardiac arrest and constipation, kidney stones, muscle weakness, and excessive urination, polyuria. I would know all of these, okay? Because all of them are very important. Maybe not the bone pain, but arrhythmias to excessive urination, all of these symptoms would easily be on your patho exams or your med surg, because too much calcium can cause calcium or calcified stones, type of kidney stone. Constipation, too much calcium can make you constipated, right? That's why too much dairy products are not good for constipated patients. Muscle weakness and excessive urination, okay? So those are really important. Now, the reason that you might see muscle weakness is that whereas hypocalcemia or low calcium levels were more stimulatory, hypercalcemia causes like a sedation. So it causes like a muscle weakness. So as I said, the really important ones to remember would be the arrhythmias, the constipation, the kidney stones, Okay. You also want to remember the excessive urination and that muscle weakness. Now, this is caused by hyperparathyroidism. Okay. So high calcium levels are caused by hyperparathyroidism because an increase in that parathyroid hormone is going to cause an increase in the calcium levels. Okay. How do we treat hypercalcemia? Well, we're going to reduce those calcium levels and we're going to increase mobility and give fiber for constipation. I think the most important point here is giving that fiber for the constipation because the constipation is one of the most common symptoms that you see in hypercalcemia. Okay. So as I said, I don't need to repeat anything because hypomagnesia, which is normal magnesium level is 1.8 to 2.6. Sorry, I'm just making some changes. 1.8 to 2.6 is normal magnesium levels. Hypomagnesemia mimics hypocalcemia. So low magnesium levels are the same signs and symptoms as low calcium levels, okay? So nothing else needs to change, just that you need to know that for hypomagnesium, I'm giving magnesium levels, okay? I'm going to give them that, and it's caused by alcoholism or GI losses, especially that alcoholism. I remember for magnesium, that magnesium is caused by alcohol, taking in too much. Hypermagnesia, or a level of magnesium greater than 2.6, has the same exact symptoms as hypercalcemia. So as we said in hypercalcemia, that constipation, the kidney stones, the muscle weakness, the excessive urination, all of that stuff, that's the same symptoms in hypermagnesia. Whereas for hypocalcemia, where we had the cats go numb mnemonic of the convulsions, arrhythmia, tetany, seizures, that is the exact same as low magnesium levels, same signs and symptoms, okay? Nothing different. But the management is that with the magnesium issue is treating the magnesium. So am I going to give some magnesium or I'm going to reduce? And now always with hyper things, we're going to reduce those levels of electrolytes. But if they're low, we want to give them that electrolyte. Now, something that I want to also add is that phosphorus and calcium have a relationship too. Phosphorus is a tricky one because it's inverse, okay? So when you have high calcium levels, your phosphorus levels go down. So when you have hypercalcemia, you also have hypophosphatemia, or a phosphorus level less than 2.7. Okay, so the symptoms of hypercalcemia are the exact same in hypophosphatemia, okay, which also means that hypophosphatemia is caused by hyperparathyroidism because the parathyroid hormone controls calcium, but in return, when calcium goes up, phosphorus goes down. So that is why a cause of this is hyperparathyroidism. It can also be caused by alcoholism. With these patients, we want to watch out for mental status changes, right? Things like that. And we want to increase their phosphorus, okay? We can find that in beans and you could also find it in chocolate. So, as I said, calcium levels, high calcium, hypercalcemia, has the same signs and symptoms as hypophosphatemia. So they are the exact same, okay? Hyperphosphatemia relates to hypocalcemia, which also relates to hypoparathyroidism, okay? So that is a phosphate level greater than 4.5, or a high phosphorus level means that we have a low calcium level and we have hypoparathyroidism, which also means, okay, that the symptoms of hypocalcemia, or cats go numb, is the signs and symptoms for phosphorus. The only difference that we do here is that we're going to try to reduce this by increasing our calcium levels. We're going to treat hyperphosphatemia by reducing foods in high phosphorus, and we want to increase foods in calcium because they will have hypocalcemia when they have high phosphorus levels. So if they have hypo or low calcium levels, we want to replace those. And calcium is absorbed better when you take vitamin D, so we want them to have vitamin D supplements. And when they are taking anything with calcium. The same thing with hypocalcemia. We want them to have vitamin D supplements when they're trying to increase their calcium intake. Lastly, I have this beautiful chart, which I love, that I've created myself, on metabolic alkalosis, acidosis versus respiratory acidosis, respiratory alkalosis, okay? So let's start with the respiratories. Respiratory, I always think opposite. So when the pH is low or high, the CO2 is going to be opposite. So in respiratory acidosis, we have a pH of less than 7.35, which means we have a CO2 level greater than 45. This means we have hypoventilation. This is because when we have hypoventilation, we have that hypoventilation because when the pH is low and that CO2 is high, it's like a compensatory mechanism. So that pH is getting really low. It's getting acidotic. So as a result, that CO2 is increasing. And that CO2 increasing in our blood is telling us that we're not breathing it off. So if we're not breathing that CO2 off, we're going to have hypoventilation. So respiratory acidosis means that we have hypoventilation, which is why we have that increased CO2 and decreased pH. Respiratory alkalosis is when we have a pH greater than 7.45 and a CO2 lower than 35, because normal CO2 is 35 to 45. And it causes hyperventilation. Same reason. If the pH is high, the CO2 is low, and the CO2 is low because we're breathing it off too much. We're breathing so heavily that we're reducing all that CO2, which is going to cause our blood to be more alkaline or more basic, and is going to decrease our CO2 because we're breathing it off so quickly. Now, metabolic acidosis is a little different. Metabolic acidosis means a pH of less than 7.35, but also a bicarbonate level less than 22. Normal bicarbonate is 22 to 26, okay? And that's associated with renal failure. And the thing with that is I think that metabolic means the same. So if one decreases, the other decreases, where respiratory, it's opposites. Metabolic alkalosis is a pH greater than 7.45 and a bicarbonate greater than 26. And that's caused by NG tubing and vomiting, okay? That's because when you suction all of that gunk out or you vomit, your electrolytes are going to get low, which is going to cause more of an alkaline environment. Whereas in metabolic acidosis, renal failure is going to cause those electrolytes to increase and create the body to have more of an acidotic state, okay? And when you get questions, this is how you need to look at it. What is my pH value? Is it below 7.35 or greater than 7.45? Okay. Which value is abnormal? Is my CO2 level abnormal, or is my bicarbonate level abnormal? They're not both going to be abnormal. It's going to be one of them. So that's how you're going to be able to figure out what the answer to the question is. Okay. So you need to look and see what the differing values are. So the pH is going to tell me, is it acidotic or alkaline? If the bicarbonate's abnormal, that's going to tell me I'm dealing with a potential metabolic issue. If the bicarbonate's normal and the CO2 is off, then I'm dealing with a respiratory issue, but which one? Okay. And knowing the hypoventilation, hyperventilation for those two, and the renal failure and the NG tube for the causes of them, knowing those causes or what it can be resulted from is very important. So hyperventilation can cause respiratory alkalosis or vice versa, right? But here's a tricky thing too. One more point. Metabolic alkalosis will cause respiratory acidosis, and metabolic acidosis will cause respiratory alkalosis. So this one and this one are paired, and this one and this one are paired. So when you have one, you have the other. Think about it. It's compensatory. If I have metabolic alkalosis, I'm going to have respiratory acidosis to compensate, and vice versa. Okay? So you could leave this in the comments if you try to do that. I'll let you know if you're right or wrong. I'm going to share on the whiteboard a question to practice those pH values, because I know that on your exam, you're going to have a question on interpreting those electrolyte levels. So if you have a pH of, I'm just going to give an example, 7.5, Okay. If you have this question and this is on your exam and they ask you, what are they in? Are they in metabolic alkalosis, acidosis? Are they in respiratory? This is where you need to figure out what are they in. So in the comments, if you wish, this is your practice question and you could tell me what you think the answer is. But good luck studying and I really hope that helped.